Good morning, class. Our topic for our lesson today is portable chest radiograph. The objective of our lesson for today, at the end of this lecture, you will be able to identify and list the necessary step toward obtaining quality portable radiographs for non-ambulatory inpatients. You will be able to display appropriate patient care and safety during portable chest radiograph. And finally, you will be able to demonstrate and explain how to position a patient for portable chest radiograph exam in the patient's room. Before we go into today's lesson, I would like to do a quick recap and summary of our last lesson on introduction to portable radiography. Portable radiography is a section of diagnostic imaging in which radiographs, X-ray, are obtained at patient bedside inside the patient room with a motorized portable X-ray machine. When do we do portable radiographs? One, when our patient, mostly inpatient, are not ambulatory, they cannot be transported or moved to the department for their examination. ICU patients who are mostly intubated, mechanically ventilated, with a lot of IV lines, very sick, or when the surgeon requested for a radiograph exam during a procedure. Lastly, for post-surgery patients who cannot be moved to diagnostic department for their exams. And now, as we all know, 85% of the portable exam performed in most hospitals are chest examination. As you remember in the last class, I showed you guys what the portable machines looks like, the image receptor. I would like to just show you this quickly. This exam pictures, an exam being done in ICU rooms, another exam, the radiographer getting ready, preparing for a portable or abdominal X-ray. For today's lesson, the technological teaching tools I'm going to be using is called Plickers. How does Plickers work? Plickers will help me in assessing your understanding of the concepts we are going to be learning today and your engagement with the material. I will project onto the screen questions, and you guys will answer them in a real time. The question will come on A, you answer immediately, and your answer will show up on my phone screen. And I can be able to see those of you who got the answer right and those who didn't get it right. This will give me the accurate picture of how you are following the information, and I can adjust the lesson accordingly. So I put the question on the screen. You guys answer in real time. On my screen, I will be able to see those of you who got the answer right and those who didn't. With that, I can be able to adjust the lesson accordingly. Okay, let's get into today's business. The necessary steps in portable chest radiograph. First of all, when you get a request for a chest exam, the first thing you have to do is patient identification. We have to make sure we are doing the right patient by matching the patient MRN with the one we have in our request, so that we are doing the right patient and right exam. This is part of the Joint Commission recommendation. And again, two things you have to check: patient MRN, medical record number, and the patient's name. Next, we have to establish an effective communication with the primary nurse for the patient. With this, it will make the job easier for you, because with good communication, you'll be able to get the patient history, support from the primary nurse, knowing whether the exam can be done in a supine, semi-erect, or in an erect position. Infection control. As we all know, there is a great deal attached to proper infection control, especially with mobile machines. In our own case, our machine is being moved from one patient's room to another. So it's very important that we are cleaning our machine before, during, and after examination. This will prevent nosocomial infection, which is well known now as hospital-acquired infections. We can be able to avoid this by cleaning our machine before and after each examination. Proper hand hygiene, the 5 moments of hand hygiene, and using the right protective apparel, PPE, for isolated patients. So we should always have it at the back of our mind for us to protect ourselves, our patients, the next patient, and the surrounding environment. We'll continue with the necessary step. You have to try as much as possible to avoid artifacts on your image. How do you do that? You have to make sure you remove objects like the ECG leads and other objects that will show up as artifacts, or that doesn't supposed to be in the area of interest of the image you are obtaining. By doing this, you are preventing repeat exams, because once there is an artifact on an image that could obstruct area of interest, then there will be a need to repeat. But once you take care of this at the beginning of the exam, then there will be no need for a repeat exams. As we all know, ALARA, as low as reasonable achievable. The next is positioning your patient. This is a very critical step, because if you position your patient right, there's high chance you are going to be obtaining a quality image. With the proper positioning, there will be no anatomic cutoff, no motion on the image, and rotation. You will prevent rotation, because whether you are doing your patient supine, semi-erect, or in an erect position, once the patient is properly positioned, then we will be able to prevent anything that might require us to have to repeat the exam. Next one is selecting the right exposure factor, our KVP and our mass. This is very important. Whether you are using the automatic exposure control or you are going to be selecting your factor manually. Some patients are average size, some are obese. So, you will not be using the same factor for a pediatric and an adult patient. So, adjusting and using the right technical factor will prevent you from producing either overexposed image or underexposed image. Either of these could lead to a repeat examination. Again, always have it at the back of your mind. Your goal is to always get a good exam the first time as much as possible. Most X-ray exams are obtained when the patient has taken in a deep breath. Most of the portable examination, it will be hard for you to give breathing instruction to your patient. Imagine you have to do X-ray for a patient in ICU. Patient is on mechanical ventilation. So what do you need to do? You have to try to observe when the chest rise up or is falling down, and be able to make your exposure at the right moment. We all know why it's good to take X-ray when our patient has taken in ear. We went through this when we are doing the departmental X-ray exam, why we have to give instruction to our patient twice. Take a deep breath in, blow it out, another deep breath in, hold it, then you make your exposure. The same thing could be done on portable. If your patient can follow your instruction, you give the instruction to the patient. If the patient cannot follow the instruction, you have to observe. Very important. After making your exposure, the next thing you have to do is post-production, especially with the new machine that is being used now, digital radiography. You can easily do your cropping and putting your annotation in the exam. This is very important because when you put correct annotation, this will help the doctor in giving a good diagnostic report as well. If you do a patient in a supine position, you have to indicate on your image. If you do it in AP sitting, you should be able to indicate it. If you do a DQ, you should be able to indicate it on your exam. If the exam is done in PA or AP. After doing this, now the image exam has to be sent to the system, PACS, Picture Archive. If you perform an exam, you don't send it to PACS. The exam image will remain on the machine. Until you do this, then you can go to the next step of documenting your examination, which will give the other area in the hospital to view the image for our radiologists to make the necessary report regarding the exam. A timely documentation helps the requesting physician to do the next thing they have to do with the patient. Delaying documentation could have adverse effect on patient care. So we should try as much as possible to do our documentation as soon as possible. As you can see, each and every step is very, very important. Up to this last stage where we document our exam. So guys, I want you to try to pay attention when you are doing your study or when you get out there in the clinical, when you get to your clinical site. Now, I would like to talk about the appropriate patient care and safety during portable radiography. First and foremost, it is your responsibility to protect the patient, yourself, and other healthcare professional and patient family. What this means is that we are dealing with radiation. It's necessary for you to make sure at least 2 lead apron on your machine, because sometimes you might need someone to hold the patient for you. They have to wear a lead apron. And you yourself as a radiographer must always try to make sure you have a lead apron on. If you can communicate with your patient, try to obtain their permission for the exam, because our patient has the right to refuse an exam. All you just have to do, you have to inform the primary nurse. But in case of ICU patient, what do? You have to communicate with the primary nurse, as I've spoken earlier. You have to check, is this exam actually was requested for the patient or not, because sometimes there could be double requisition. So to prevent unnecessary radiation for our patient. The next step is to make sure you explain the exam to the patient if the patient is one that is responding. Hey ma'am, sir, I'm going to be doing chest x-ray for you. I will need you to sit up for me. I'm going to be putting this cassette behind. Kind of communication like that. Gaining patient cooperation makes your job a lot easier. And always remember, when you position the cassette, your patient, you put the cassette in the proper place. Never put your hand in the primary beam. This is for your own safety, okay? Ownership. Whenever it's possible, always try to protect your patient with a lead apron in their gonadal area. This is very important. Yeah, let's assume there is no need for anyone to hold the patient. You can use one of the lead apron to cover the patient gonadal area while you wear the other one. In case someone's going to be holding the patient, you can use the other one to protect the patient and you stand as far back as possible away from the patient. And ask whoever is in the room for them to step out. There's no need giving scatter radiation to people who are going to be maybe family patient. Ask them to politely to give you like 2-3 minutes. After the exam, you can come back in and try to announce in a kind of loud voice, X-ray, before you make the exposure, so that this will give people around to be able to move away from the area. Yes, uh, our image receptor. Always try to put it in a plastic bag or a pillowcase because it's cold. This is part of patient care. Try not to put a cold cassette receptor behind the patient. Make them to feel comfortable as much as possible. Only just imagine yourself being the patient. How will you feel in the middle of the night? Someone just comes to your room and put a cold cassette behind you. I'm sure you're not going to like that. So let's always think about our patient first. Patient care always. Manipulating equipment. There are certain things we have to watch out for when we are doing portable chest X-ray. As we know, especially in the ICU, as you can see from the picture I showed you earlier on, there are many lines attached to the patients. We have oxygen tubing, equipment power supply in the room, intravenous IV lines, the catheters. You have to make sure you are very careful, you are not doing anything that will pull any of these out from the patient. And again, this is why you need to have good communication with the primary nurse. If you communicate with the nursing staff, believe me, it will make everything go smoothly for you and for them, and who benefit? The patient. Watch out for the overhanging TV in patient's room. At the same time, watch out for your the tube of your machine also, because once you position it, you have to make sure you are not like walking around in such a way you can hit your head on the machine. And always try to achieve the maximum distance. At least try to stand 90 degrees away from the patient. This is, you all know, time. Remember the three cardinal? Time, distance, and shield. Moving away is distance. As we know, there is like a minimum 6-foot exposure cord in the portable machine. So the cord attached to the machine for the exposure give you chance to be able to move as far back as possible before you make your exposure. Now, I'm going to be introducing to you the major three positioning that you will be encountering on portable. The first and foremost is AP chest supine. This is mostly for very ill patients who are very sick. You cannot see them all. The exam must be done supine. This can either be in adult or in pediatric. You have to remember this. In the neonate, most of their exam is supine. So you cannot sit the baby up. So it's going to be mostly supine. So always have at the back of your mind what needs to be done. This entry ray is always perpendicular to the chest. Seems like when you are doing departmental, the T7 is where the central ray has to come in. And you should try to achieve minimum 40 inches or 100 centimeter distance. If the patient can be done in semi-erect or AP sitting, this is better than supine. But why do we do portable in the first place? For patients who cannot come to the department. So don't force it. Patient who is very sick, try to do it the way it will not affect the patient comfortability or have negative effect on the patient health status. The next is the AP chest semi-erect or the erect. In this case, you're going to be sitting the patient up in a semi-erect or erect, 45 degrees. The central ray must be aligned to the chest, and you have to maintain a perpendicular image central ray to the image receptor. So if you position your patient this way, you have to make sure the central ray is going this, it must be perpendicular so that you don't have what? A lordotic chest X-ray. In which case the clavicle is like way above the lungs. This we will go through it in our next class. XID here, you just try to be as far as possible. There are few different school of thought here. I just try to keep the maximum you can do for a chest X-ray. In many instances, you might not be able to achieve the 180 centimeter due to the patient's room, okay? So, not too close, as far away as possible. The next one is the lateral decay. We all know lateral decay. The reason why the doctor might request this, you might not come across this most of the time, but I have to bring it into this class just for you to have an idea that sometimes lateral decay, when they request it, you have to turn the patient on the side. This is mostly to see the air flow level. So you put the patient on the side, depending whether they want left lateral or right lateral. That will determine what side you are going to be putting down and the one that will be on top. You put your cassette behind, you have to angle your portable tube, and you shoot same way. Central area has to be horizontal to the mid-torus. You, like I said earlier on now, the same thing. Try to achieve the maximum source to image distance. This exam is very critical for you to put the right annotation for this exam. If the right is up, make sure you label this side right up and indicate on the image the type of lateral decay it is. Right lateral decay, left lateral decay. And we go through lateral decay more in the next class. So far so good. If you have any question, don't hesitate to stop me, and I will be more than happy to address it now or at the end of the class. Supine position. I will just want to bring this to your attention. Convenience should not be the reason why you must do your portable chest X-ray supine. No. Often, patient instability is the factor that determines whether or not the patient should be positioned or the exam should be done upright or supine. Like I said earlier on, a very ill patient, hypertension patient, post-surgery patient, most of those patients, you cannot sit them up. You have to do the exam in a supine position. The supine position should be used only when the physician indicates it, or the patient not recommend it due to the condition of the patient. As I said few seconds ago, the patient condition is one of the determining factors whether the exam should be done supine or upright. And proper communication with the primary nurse is very important here. Again, don't just go into a patient's room without first communicating with the primary nurse. Another reason why this is very important, apart from patient care, safety, if anything happens while you are in the room and the nursing staff is not with you, you did not have any communication before going in there. You don't want an IV line to be pulled out from the patient that could cause something we don't want to our patients. But once you get understanding of the nurse, the cooperation of the nurse before going in there, most of the time the nursing staff will be with you in the room while you are doing the exam. Okay? So if anything happens, at least she can be there to quickly prevent any adversity from happening. Okay? So always remember, supine should be the last option when you are doing portable X-ray. I will explain this in the next or the second the next slide. Okay, exactly. So I will quickly just go through this for you. These are the example of the scenarios for supine portable chest X-ray. Trauma spine precaution. An MVA patient brought into ER, they have not determined whether there is like a C-spine fracture, T-spine fracture, or any other fracture on the patient. We cannot move this patient. And the doctor needs to see the chest X-ray. As we all know, when a patient is brought to ER, one of the first things they have to do is chest and pelvic portable. Don't even drag anything here. Have in mind, the exam is going to be done supine. If the doctor now wants it to be done semi-erect or AP sitting, then they must have cleared some other stuff. At least you are getting this from the doctor or the primary nurse. You are not going to be determined that the exam must be done AP sitting here, okay? Or a patient who just had a spine surgery and they need to do the chest X-ray. No need to do the exam as an AP. Or a post-cardiopulmonary resuscitation patient, CPR patient. They call it a CCRT code, and most of the time X-ray will be required. When you get to the room, put it in your back of your mind, the exam has to be done supine, except the CCRT team now asks you to do the exam in an erect position. Unstable low blood pressure patient, hypertension patient. When you pull them up, that will cause an adverse effect, a negative, uncomfortable for the patient. So, again, reason why you have to communicate with the patient. The patient might look not so sick to you, but you cannot sit the patient up. These are some of the major scenarios whereby supine is okay. We don't force anything here. Patient care, their safety is of more paramount than any other thing. We should be patient advocates. Now I will show you the reason why whenever it's possible, and most of the time it will be possible, to avoid doing the X-ray in a supine position. First, the lung field most of the time will be foreshortened. It will be small. Imagine lying down, supine. What happened? The abdomen pushed the lungs up. So on the image, the lung will look not full, but short. The second one, the heart tends to be magnified when patient is in a supine position. That is why portable X-ray is a limited exam, but it is necessary. Last but not the least, when a patient is in a supine position, it is hard for us, the radiologists, to visualize the airflow level. You know what I mean? Under the claustrophobic on the diaphragm, when the patient is done in a supine position, it is difficult to visualize the airflow level. So, these are some of the reasons why it is mostly advisable to do our portable chest X-ray AP supine. There must be a reason the exam has to be done in the supine position. If there is no reason, no indication, try as much as possible to obtain your portable chest X-ray in a semi-erect or sitting position. I'll just show you some quick picture. We spoke about artifact. That's an artifact there. If you can move it away, move it away. Look at this chest radiograph with artifact. All this could be avoided either by removing the ECG or by asking the primary nurse to move it on the side. Take a look at this. This X-ray, I can tell that it is done in a supine position. You see how the heart seems magnified, the lungs foreshortened. You cannot compare this to this. This is an AP sitting chest radiograph. Seems like it was done in the department. This exam, this quality image was obtained because all the necessary steps that need to be followed occur in obtaining this image. So, this is our main goal and target. As you can see, we have almost come to the conclusion of today's lesson. But before we end this lesson, I would like to do a quick roundup, and after that, we can call it a day. Try to go over this lesson with the introduction that we did last week regarding the introduction to portable radiography. So, combining the introduction and the portable chest radiograph together, we help you when you go to your clinical. I believe, do you guys have clinical tomorrow? Okay. So, at your next clinical, make sure before you go through your handout for the introduction to portable radiography and to this lecture. because I believe at your next clinical site, portable radiograph with emphasis on chest exam, the one we go through today, is going to be part of your clinical practical observation and competency for next week. So, if possible, you hand out for last week, introduction to portable radiography, and today's lecture, portable chest radiography. Take it with you to your next clinical visit. I'm sure you all know what to do. Revise, and at your clinical site, try to ask your clinical coordinator and whoever you are going to be assigned with, the staff radiographer on portable. You have to demonstrate, but first of all, observe. Try to make sure that you can see for yourself that everything we just went over today, you can have to have your own checklist before you try to obtain your competence. So, with that, I wish you good luck. I'm very sure that at this point we've covered everything that needs to be covered regarding portable radiography. Because chest portable is most often performed exam. That's why we have to really talk in depth regarding this exam. So, if there's any question, I believe we have 5 to 10 minutes to address any of your question. And if there's no question, so you have extra, I believe, 5 minutes for you to leave early, take your break before your next class. So, no question. Okay. Have a good day, class. And thank you. See you next week. Bye.